So for our last installment of the urinary system, we're shifting our focus to homeostasis. Remember that term. We're never going to escape it, right? Our body's always going to maintain relatively narrow framework. Temperature can't be too high, can't be too low. pH can't be too high, can't be too low. There's very, very narrow parameters that we have to stay within, and the urinary system plays a really large role in that. So let's look at how the urinary system helps us maintain homeostasis. So the first one is that we're getting rid of waste, right? We're not allowing waste to build up. So things like urea and uric acid, these are things we don't want to keep around. And so we get rid of them. That helps us maintain homeostasis. We're also maintaining our water-salt balance, which is helping us maintain blood volume and pressure, our pH balance, as well as help that it can provide to other systems. When we're looking at homeostasis and how the kidneys or the urinary system in general can help, there's one location that we want to look at, and that's within the nephron. So remember that afferent arteriole. That afferent arteriole is bringing blood into our capsule. And then the distal convoluted tubule is where we are kind of at the end point of the nephron. Now, when we looked at the image, it was flattened out. So it was two-dimensional, and we could see every single part, and nothing seemed to really be touching. However, in reality, that distal convoluted tubule actually folds over and touches onto a certain point where the afferent arteriole is at. Right where these two touch, where the afferent arteriole and the distal convoluted tubule touch, we have a location where we can secrete our hormone called renin. Renin, if you remember from earlier, is going to trigger the adrenal cortex to produce aldosterone. And so here's our image. So in our image that we saw previously, everything was laid nice and flattened out. However, things actually kind of fold over on each other. And so we see that that capsule, our Bowman's capsule, actually kind of folds over this way. And our afferent arteriole actually kind of nestles itself on the distal convoluted tubule. Now, we're not connecting these two nephron parts. Instead, we're creating this little area right here where we can produce and secrete renin. That renin is going to trigger your bodies and trigger your adrenal glands to produce aldosterone. Aldosterone is going to help us keep sodium while getting rid of potassium. So it's going to help, aldosterone is going to help us reabsorb salts, which is going to increase our blood volume. Now we have a hormone that works in reverse or an opposite of aldosterone, and that's atrial natriuretic hormone, or ANH for short. Atrial, that should make you think of the heart, right? Think atrium. Natriuretic has to do with sodium. Remember, sodium's symbol is Na, as we see here. So if you see this, you should think sodium. So something with the heart, something with sodium, and it's a hormone. So atrial natriuretic hormone is secreted by the heart when blood volume is high. So when blood volume is high, we don't want to keep salt at that point because we don't want to increase the blood volume anymore. We're already at capacity. So ANH is going to stop aldosterone, and that's going to allow us to excrete sodium instead. So renin promotes aldosterone, ANH inhibits aldosterone. So you think of renin and ANH as working in opposite of each other. We'll talk about more hormones throughout the semester that also work in opposite of each other. It's that negative feedback that we've mentioned before. But for now, we're going to focus on renin promoting aldosterone, which lets us keep sodium, and ANH, which prohibits or inhibits aldosterone so that we can excrete sodium. In addition to that, we also need to look at how we reabsorb things like water. So when we are reabsorbing, especially when we're in that loop of the nephron, we're diving down into the medulla and coming back up to the cortex in our nephron. There's actually a concentration gradient going along that dive down and that steep climb back up. There's a higher concentration of solutes as you get to the bottom of that loop, down at the bottom of the U shape. So you have a lot of solutes down at the bottom and very few solutes up near the top. So as we move down that loop, we're going into greater concentrations of solutes. Water is going to get pulled out of the nephron into those high concentration of solute areas. Remember, water wants to dilute the high concentration. We're using the properties of osmosis here to reabsorb water. To help with this process, we also have antidiuretic hormone, or ADH, that's coming from your pituitary gland to help with water reabsorption at the collecting duct. So after we've already made our way through the entire nephron, we want to reclaim a little bit more water, and we can by using ADH. So let's look at this in motion. We have our high concentration of solutes down here. We have a lower concentration of solutes up here. So it's hypotonic up here, it's hypertonic down here. So as we move down our loop of the nephron, water gets pulled out to dilute that high concentration. I mean, think of water going from a high concentration of water inside the loop to a low concentration of water outside the loop. So that's one way we can reclaim water. As we go back up, right, our concentration of solutes is going to be high down here and low up here. So as we move up, we can also reclaim some of the salts as well. So we can reclaim some salts because the concentration of the solutes is really low up here. We make our way through the distal convoluted tubule, we get to the collecting duct, and then our ADH, our antidiuretic hormone, can help us reclaim water at the last minute before we make our way and become urine. Now, if you've ever drank a good amount of alcohol, for those who are 21 and older, we'll pretend that no one drinks under 21. But if you're 21 or older and you've consumed alcohol before, you may have noticed that you have to use the restroom more often. Some people say that they have to break the seal, right? And you probably also noticed that your urine is clear, much clearer than it would be under normal circumstances. So why? Why does alcohol make you pee so much, and why is that pee so clear? It turns out that alcohol actually inhibits ADH, which means you're not able to reclaim that water as you move through the collecting duct. You're going to lose more water because you're not able to reclaim as much as you could if you didn't consume any alcohol. So that's why you have to urinate so much when you drink. It's why it tends to be clear, because there's a lot of extra water in your urine that normally your body would keep. This does lead to dehydration, and that's one of the reasons why you can feel so crummy the next day. So if you are going to consume alcohol, it's always a good idea to hydrate with water while you're drinking. Have a drink, have some water. And of course, don't overconsume. When it comes to maintaining pH, this is where the hydrogen ions and the bicarbonate come in. Buffers can take on extra hydrogen ions or extra hydroxide ions. When we have a lot of hydrogen ions in the blood, something like bicarbonate can pull up that extra hydrogen ion. When there's extra hydroxide ions, which make the blood more basic, same thing, we can pull that up as bicarbonate. So bicarbonate is one of those molecules we were trying to keep in the kidney because it serves as a buffer. It's going to help us maintain balance with the pH. Now, we mentioned getting rid of carbon dioxide when we talked about the respiratory system, and that carbon dioxide is acidic. So you might be thinking that the respiratory system handles pH for the blood. Why are we talking about the urinary system? Well, the respiratory system can only do so much. It can only help moderate the pH concentration so fast. And it's not fast enough to really truly maintain pH. So the ultimate control of pH for the blood is coming from the kidneys. because they can actually get rid of those hydrogen ions at a much larger, much faster pace. And so we see that here. We're reclaiming bicarbonate, we see right here. And those hydrogen ions, we're able to secrete them into the kidney, right, into the nephron. Remember, that's that third step of tubular secretion from urine formation. So hydrogen ions are able to be pulled from the blood and be placed into the nephron to be part of urine. Of course, we can't escape without talking about what can go wrong. And there's a handful of things. So let's get into some infections and inflammation conditions first, and then we'll dive into some other things. Urethritis, think itis, right? Itis tells you inflammation or infection. Ureth tells us something about the urethra. So this is just an infection found in the urethra. And this can be caused by multiple agents, multiple pathogens like chlamydia, trichomonas, gonorrhea, and candida, aka yeast. All of these are potential pathogens that can cause urethritis. Cystitis, itis again, so it tells us infection or inflammation. Cystitis is an infection of the bladder. And then pyelonephritis. Itis tells us infection, but pyeloneph, maybe not as straightforward. But neph, that sounds like nephron. And nephrons are going to be found in the kidneys. So pyelonephritis is an infection found in the kidneys. Some other things that can happen, things like kidney stones. This is where you actually have hard granules that are found in the renal pelvis because of maybe a urinary tract infection. Maybe if you're male, you have an enlarged prostate, you have a problem with pH balance, or if you're taking in too much calcium or protein. So kidney stones, these are relatively common and they can be very painful. And there's a wide variety of reasons of why someone might end up with kidney stones. Uremia is when you have too high of a level of urea or other nitrogenous waste in the blood. And this is because your nephrons are damaged and they're not able to actually filter the way they could if they were healthy. So uremia is basically your kidneys are not working to their full capacity. They're not able to filter out all this nitrogenous waste, and so the nitrogenous waste builds up in the body. So if someone has a problem, especially with the kidneys, what can we do? So if we have kidney failure, and that doesn't mean it's 100% like your kidneys are totally toast, but they are not working at capacity and they're not working at a high enough rate to actually help you. You're getting sick because your kidneys are not working at a good enough capacity. What can we do? Hemodialysis is one option, also known as just dialysis. That's probably the more common term, is they drop the hemo. But for this, you're using a machine that's going to act like a kidney. It's going to do all the filtering. It's going to make sure that everything that needs to stay in the blood stays in the blood. Everything that needs to be removed gets removed. This, though, is a challenging process. This is something a person would have to endure multiple times a week. And as you can see in the picture there, that person is not able to necessarily go about their normal life, right? They're in a clinic, they're in an office, they're hooked up to a machine. They're not able to freely just get up and walk around or go somewhere. You could see how this could really impact someone's life. A better way to do this would be continuous ambulatory peritoneal dialysis, or CAPD. This is where you're actually using part of your body to help filter the blood. And then worst case scenario, or I could say if you're on dialysis, maybe best case scenario, is that we actually just do a kidney replacement. They take another kidney from a donor, and the donors can be living or deceased. But we take a kidney from a donor and we implant it into the person with kidney failure. Oddly enough, they don't necessarily remove the old kidneys. They'll just pop the new one in. But that's something that could be done. It's a very common transplant, and it's a relatively successful one, especially compared to other transplants. That being said, someone who receives a kidney transplant would have to take immunosuppressive drugs. And since we've learned about those already, we know that that does open this person up to problems with infection and disease.